Hello, everyone. My name is Mary Muko. I'm a specialist on the Provider Outreach and Education team at WPS Government Health Administrators, or WPS GHA. I will be your speaker today. Assisting me is my friend and colleague, Bailey Lawson, and other members of the Provider Outreach and Education team that may help during the question and answer portion of today's webinar. This is a disclaimer statement, and we do include this in all of our education. And the reason we do this is to remind learners that although we made every effort to provide current and correct information, the information is, of course, subject to change. We will provide responses to questions based on the facts given. It is on the CMS website where you will find the Medicare rules that do determine final Medicare coverage. And these laws, regulations, and rulings will always prevail. And as a reminder, CMS prohibits recording of this presentation or any of our presentations for profit-making purposes. So let's get started today. This webinar is advertised as a topic where we will be talking about ambulatory surgery center rejections and denials. And specifically, those are the charges that we're looking at that came in on those Part B claims, those claims submitted on the CMS 1500 claim form if you're submitting claims on paper, or the 837P electronic claim. Now, this webinar is designed as kind of an entry level. We're not going to dive deep into the information, but it will provide information to you about Part B ASC claim rejections. I'm also going to talk about denials and talk a little bit about the difference between a rejection and a denial. And then, of course, I want to provide information to you so that you're able to fix these or avoid these in the future. And then finally, we will conclude with answers to learners' questions. I do want to thank those of you that submitted questions when you registered for today's webinar. I did receive some questions or topics that some of our learners want to hear about. So I've incorporated answers to questions and those topics into my prepared remarks if they were indeed topics that we advertised we were going to talk about today. But before I dive into the rejections and denials information, I really want to step back and talk a little bit about the remittance advice, or what you'll hear us call the RA. Sometimes we call this the remittance notice. I want to talk about the importance of this. The RA is either an electronic or paper notice that a provider receives when a claim is either rejected or processed. And it's going to provide notice of rejection or include the information about how that claim was adjudicated. So depending on how the claim was processed, it may include information about any adjustments made to the claim or even denials. Now, it could also include information that something's missing, and sometimes it provides notice about refunds or even offset. The RA includes codes to convey information to the provider or the provider's staff. Claim adjustment reason codes, we call those CARCs, they explain why a claim paid differently than it was billed. Remittance Advice Remark codes, known as RARCs, provide more details about a claim adjustment that is described by the claim adjustment reason code. The last type of code is a claim adjustment group code, and this is a code that conveys details about financial responsibility for those amounts that are not paid by Medicare. So a CO is a contractual obligation, and it means the provider is liable. A PR code on your remittance advice would mean that it's a patient responsibility, and that simply means that the patient is responsible for payment. Now, these codes are not codes that WPS GHA creates. These are maintained for CMS by a company named Washington Publishing Company, and this company actually publishes a list of those CARCs and RARCs and those group codes out on their website. And you can also use the Reason Remark Code Lookup tool. Now that's a tool out on our website, so it's on one of our web pages in order to find details on any code that appears on the remittance notice. So just a few resources for you. I know when I advertised this event, I did state that I would be providing resources, and those are provided throughout the presentation today. Just look for the embedded links in the handout materials that I prepared for the event. Next, now I will dive into the discussion about really the life of a claim and rejections and denials and so on and so forth. So this then is a simplified graphic that shows how your claim gets into the claims processing system, the multi-carrier system, or MCS. That's the system that would house and pay or deny those Part B claims, those ambulatory surgery center claims that we receive at WPS-GHA. So it begins, of course, with the provision of the service. The provider then, or the provider staff, would submit the claim to Medicare, and most claims are submitted electronically. And the system will actually look over that electronic claim kind of when it comes in the door, if you will, and either allow the claim to come into WPS-GHA or reject the claim. And there is actually reports that are generated when that happens. For an electronically submitted claim, providers need to review either the 999 or 277 report, or both of them. The 999 report is one that's going to verify if that claim was actually accepted into the claims processing system. It lets you know that the claim was received and accepted. For Part B claims, of course, it's, as I mentioned, the multi-carrier system, and sometimes we refer to that as MCS. The 277 report provides more specific information, and on our electronic data interchange website, and I've included the link for you, you can go out to that website and actually see a listing of reports. And there is a link to the Medicare 277 or 276, 277 companion guide. And this companion guide will help you understand the content that's in that report that's sent to you. It's going to clarify and supplement and further define the data content in that 276, 277 companion guide. Those reports collectively are going to define any errors, and this is going to allow you the chance to correct and resubmit claims that have been rejected. Next, I want to talk about unprocessable, and this is, the claim is moving on through, it came in the door, Medicare accepted your claim, but sometimes your claim is deemed unprocessable, and these are what we call rejected claims. There's a huge difference between a rejected claim and a denied claim. And a lot of people use those words interchangeably. I know that some folks, even within our office, use them interchangeably, but they are a very different type of claim. So this is a simplified graphic that shows what happens to the claim that Medicare deems as unprocessable. Of course, the provider would provide the service, submit the claim, but when the claim comes in, it's actually accepted into the house, if you will, but something's wrong. There's an incorrect format, something's illogical, something's missing. So the claim is actually rejected, and the remittance advice is sent out, and it tells you that the claim is being rejected as unprocessable. And here then is a visual of the huge difference between a rejection and a denial. A rejection is what we call unprocessable. We can't process it. It's not adjudicated. It's actually returned on the what we call the front end of the house. We haven't processed that claim. There's missing information, incorrect information, or maybe information that's just illogical. Let me give you an example like that for an illogical claim. An illogical claim could be one where a hysterectomy is being billed for a male patient. Something's illogical. It doesn't match. Um, so those claims are deemed unprocessable, and because they're really not processed, they're not adjudicated, there are no appeal rights. You need to fix it and resubmit it. And when you receive that remittance advice that I talked about earlier, remember I talked about those group codes, those reason and remark codes, there will be a CO16 group code on an unprocessable claim. And that means that it's a contractual obligation. You can't bill the beneficiary for that service until you fix it and resubmit it. And then pending the outcome of that process claim, you would know then how much you can bill the beneficiary. Unprocessable claims will have the MA130 Remittance Advice Code. And basically what that says, the description that the Washington Publishing Company has prepared for that particular code, Remittance Advice Remark Code, is one that says that your claim includes incomplete and or invalid information. There are no appeal rights because the claim is unprocessable, and it asks you to please submit a new claim with the complete or corrected information. Denials, on the other hand, are claims that are adjudicated, so they are processed. However, the claim or the claim line doesn't meet Medicare's payment criteria, and I've listed some examples of those on this slide. There could be a statutory requirement. What that means is that the law says Medicare can't pay for this item or service. The service might not pay due to medical necessity criteria, and typically this would be associated with an edit or an audit within the claims processing system, or also an edit or audit that's due to a local coverage determination or a national coverage determination. Policies define medical necessity, and policies mean that there are edits within the claims processing system. Beneficiary eligibility is something else where a claim may fail to meet payment criteria. If the beneficiary is not eligible for the Medicare service on that particular day, then the claim would be denied. There's also frequency edits, and really frequency edits are considered a type of medical necessity denial. And medical necessity denials, including frequency, or those denied due to frequency parameters, are those claims where you will need to consider presenting your patient with that advance notice of non-coverage or advance notice of and advanced beneficiary notice of non-coverage. There, I've got the whole thing right. So the ABN form. When you have a claim that is denied, there is going to be an MA01 Remittance Advice Remark code on the remittance advice. It's going to tell you that if you don't agree with what we approved for the services, maybe we approved some of the services, not all of the services, the Remittance Advice Remark code is going to tell you you can appeal the decision. To make sure that we're fair, we're going to have another individual then review the information, but there is a time frame associated with how long you have to request that appeal, and all of that information is going to be included on the remittance advice. So after reviewing your remittance advice, and we talked about how important that is, you're going to need to choose an action. For an unprocessable claim, or what we call a rejected claim, you'll need to fix the error and resubmit the claim to Medicare. But if the claim or claim line denied, there could be multiple actions that you can choose from, and you may be able to simply resubmit the service, which is what you do for an unprocessable claim. You might also be able to use what we call the clerical error reopening. That's CER, the acronym CER, and that's a process that's used to fix clerical errors. And CMS defines clerical errors as minor errors or omissions. They're also considered a human or mechanical error on the part of the party, the provider, or the contractor. And I'll talk more about that CER process later in this webinar. Another action that you can consider is an appeal. The Remittance Advice is going to provide those appeal rights. I just talked to you about the MA01 remark code that's on the Remittance Advice. Now, registered users of our transactional portal can render a clerical error reopening or request an appeal using this self-service tool, and that is really the most efficient way to render the clerical error reopening or to request an appeal. The the portal user manual available out on our website provides step-by-step instructions. It also has some great illustrations on how to use these portal features. So if you don't know how to use those features, we do have the portal user manual available that will walk you through the process. Registered users can also use the portal to check claim status. You can look at claim details and claim actions. And when reviewing those claim details in our portal, there's actually a button that appears. It's a blue colored button, and on the button it says More Info. And this is a button that you can click when you're reviewing a claim line or a claim, and it's going to give you more details about the claim or the claim line. So if a claim denied or a claim line denied, the details are going to allow you to link to more information. So let me give you an example of that. If the claim denied based on a local coverage determination, we're going to give you a link to that local coverage determination so that you can, you don't even have to leave the transactional portal. You're going to be able to link directly to that local coverage determination. So some great functionalities are offered out there. If the claim denied due to another claim already processed, maybe it's a duplicate, or maybe the services on one claim are being denied because there's another claim that's been processed, users can link to the claim information for that claim that's already processed. But of course, this would have to be a claim that's submitted by the same provider. You're not able to access and view claim information if a claim was also submitted by another provider. And that's what's causing the denial. And that, of course, is due to privacy rules. Now, another self-service option that's offered to check claim status and details on claims is the interactive voice response, or the IVR system. Authenticated users can use voice or the telephone keypad to access claim information. And the instructions for use of the IVR are included in the IVR operating guide, and I've included a link to that here on this slide rather. Now, both tools, the portal and the IVR, are available 24 hours a day, and it is 7 days a week, not 6, with limited functionality outside of normal business hours. And if for any reason those systems are taken down, we do provide a notification out on our website. You can find that on the home page. We have messages there when there are system access problems and such. So now I want to start talking to you a little bit about the Medicare claims dashboard. And in their instructions for Medicare administrative contractors, what we call MACs, CMS states that the MACs shall use their discretion to determine the educational topics that are most relevant to their provider population. So CMS further states then that MACs shall use various sources of information, including provider feedback, policy and procedure changes, and MACs data analysis in order to determine these topics. So our data team, we call them Insight, that's the name of their department, just like we're called PO, Provider Outreach and Education. They're called Insight. They've created a claims dashboard so that people like me in Provider Outreach and Education, or someone like Bailey, any of us on our team, can quickly access data for rejections and denials on claims. However, it's only for those claims within WPS-GHA's MAC jurisdiction. So we're talking Jurisdiction 5, which is Iowa, Kansas, Nebraska, and Missouri. And then, of course, there's Jurisdiction 8, which is Indiana and Michigan. And this interactive dashboard allows us to pull data, and it is just in a matter of seconds. It's unbelievable how quickly we can pull this data. So as you can see on this slide that I'm showing now, we have options to drill down or to filter, we call it, by provider specialty. We can filter by the type of facility, even the state and the county, and even much more. So we can view rejections and denials by reasons, why did the claim reject? Why did the claim deny? Or by HCPCS codes. We can see the most common rejections or the most common denials based by code. So we can see a list of those codes, and I'm going to share that information with you a little bit later. So the dashboard, even it goes beyond that even. This dashboard allows even more drill down. We can view the total PTAN, and PTAN is Provider Transaction Access Number count. We can look at the beneficiary count. We can look even at the number of units that were submitted and rejected or denied by Medicare and the dollars associated for those rejected services or denied services. And finally, we can also view trending. We do this to determine over time whether the rejections or the denials increase or whether they decrease or whether they remain stagnant. So it's just absolutely fascinating to look at this information out on the dashboard and in a matter of seconds be able to drill down the information that we're seeking. So this slide then shows you that I used filters to pull data that I want to discuss during today's webinar. I told you that I was going to talk about common rejections and denials for ambulatory surgical center claims, specifically those Part B claims submitted on the CMS 1500 or the 837P electronic claim. The way I did this was to choose within that interactive dashboard, if you will, the specialty and the specialty code. It's assigned to ambulatory surgical centers when they enroll with Medicare. So, if you're a general surgeon, you're a zero, or general surgeon, I believe, is 02. Family medicine is 08. Psychiatrist is 26. Everyone is assigned a specialty number. And for the most part, the specialty is self-designated because we process claims based on that primary specialty that is self-designated by providers when they enroll or entities when they enroll with Medicare. So for ambulatory surgical centers, when they enroll, a specialty 49 is associated with that provider eligibility. I looked at submission dates July of 2023 through October 2023. This is a set time frame that our insight staff or our data team sets up in this dashboard for us. So typically, 3 months, 4 months, but I did pull the data. The data was refreshed shortly before I pulled data for this webinar on October 15. It was just shortly after that that I actually pulled the data so I could prepare my PowerPoint and my speaker's remarks so that I could share that information with you. So on the next few slides then, and in your handout that I prepared, you will see reasons and the number of claim lines for common rejections, common denials for Specialty 49 claims in our MAC jurisdiction, so Jurisdiction 5, Jurisdiction 8, Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan. Here are your dates. And the data was refreshed on October 15. So why is that important? The reason why that's important, when was it refreshed, is because if I'm pulling data for October claims and I'm refreshing the data on October 15th, that means that not all of the October claims are in the door yet. What happens to the 16th through the 30th? It also gives us time, for example, for those late September claims that come in. Remember that payment floor, we can't release payment on that electronic claim for 14 days. So that means if a claim came in our door in late late September, by October 15th, I know that that claim is typically processed unless there's some development done on that claim. But that just allows timing, and it allows us to get a better feel for the rejections and denials based on those accurate submission dates and process dates. So let's take a look at the data. And of course, as I mentioned to you, there's rejections or denials. We can filter by state uh, for denial reasons. We can filter by county for denial reasons and rejections as well, and so on. And we could also choose to view by CPT or HCPCS codes for denials or rejections, and we can look at trending for them. So when I say state here, that our data options are states, those are the states for which we are the MAC. Jurisdiction 5 states, Jurisdiction 8 states. I did not drill down to county, but that's available just at a touch of a button. So here then are our common rejections and the number of those rejections for the data filters that I used to view the data. I can't show you the data dashboard itself because in order to access it, I need to be within our secure environment, and I can't be in a secure environment and show you things while I'm in that secure environment, and that's due to our rules set up here at WPS so that we don't share any secure information, of course, that we shouldn't be sharing with anyone, providers, billers, coders, compliance. We can't share it with anyone that doesn't have the need to know. So here are common rejections then. Look at that first one. That is the most, that's the highest number of rejections for Part B claims submitted by ASCs, those dates I gave you. 995 claims came into us and were rejected because that claim shouldn't have come to us at all. It should have been sent to a health maintenance organization. And what that means, folks, is that that patient or beneficiary has elected to have Medicare Advantage instead of, or in lieu of, or rather than traditional Medicare, or what we call original Medicare. So if you think about it, 995 claims is a lot of claims in 3 months. These, remember, are just those claims submitted and rejected for ASC claims. If you think in terms of the entire universe of the claim of Medicare rather, that number is shockingly high. It costs money to process each claim or to bring the claim into the system and reject it in this case, because these are rejections. So, if we can lower that number, we're saving trust fund dollars. It's less costly for you, the provider, as well. You don't need to prepare a new claim and then submit it to Medicare Advantage, which is Part C. WPS GHA is not Part C. We are Parts A and B. We are a MAC. Let's look at the next one. Claim lacks information needed for adjudication. Well, that could be a number of many things. And for that one, what you're going to need to do is you're going to need to go out to the transactional portal and look for that more info button. So you can find, and actually that's only going to show the details on the denied claims, but you're going to need to look over that claim. I'm backing up. I'm mixing up denials with rejections, and I can't do that. For a rejected claim, if it lacks information that's needed for adjudication, you're going to need to look over that claim and see what's missing. Maybe you didn't include information that's required on the claim, and you can find the requirements for filling out a claim form or the electronic claim form in the internet-only manuals or in the Crosswalk that our EDI department has prepared. So look over the claim and look for something that's missing, something that we need for adjudication. The next common rejection that I have on this particular slide is that the claim must be submitted to RRB. And what is RRB? RRB is the Railroad Retirement Board. So that particular beneficiary has coverage Under the Railroad Retirement Board, WPS does not process claims for those beneficiaries. It is another contractor that processes those claims. It's Palmetto. So you would need to submit that claim to Palmetto. The next one I kind of have to chuckle at. It says denied, invalid, or missing modifier, when in fact this claim is a rejection. So I want to talk about those codes you see, those code descriptions you'll see on the remit. Sometimes they're rather cryptic. Sometimes they're a little misleading because this rejected reason or remark code says denied, invalid, or missing modifier, and it's really not a denied service. It's a rejected service, and the other codes on your remit, or that CO16, is going to be your first clue, if you will, or first tip that this is a rejected claim, not a denied claim. So 309 of those claims. This is another one. There are some trading partner agreements where if we reject a claim, we have to forward the claim on to the Railroad Retirement Board. So the rejection may be that we've already forwarded it on your behalf, so you won't need to. The next one is service report cannot be billed separately. So typically this would be something that is bundled, not covered. You would look on the relative value file that CMS has on their claims processing, or excuse me, on their website, and it would tell you that the service is bundled. You can't report it separately, so it's rejected. Missing procedure or modifier is 69 rejections for that time frame. The next one is another one I have to chuckle at. Patient or insured's HICN, health insurance claim number, and name do not match. Quite a while back, we discontinued using a health insurance claim number. It's now called the Medicare Beneficiary Identifier, the MBI, but they didn't change the description for that rejection code, that reason or remark code. So kind of like that one I talked about earlier that says denied when it's really rejected. Sometimes the descriptions are not brought up to date. You know, this one says HICN, but what it means is that the MBI doesn't match the name. And it has to match exactly. If there's a middle initial on your patient's Medicare card, you need to use the middle initial when you submit the claim. Another one, claim processed in accordance with ambulatory surgical guidelines. That one's a little bit cryptic, so you might need more information. Unable to obtain primary insurer information. That relates to those claims for which Medicare is the secondary payer. So something's missing on your claim to identify that primary insurer. The next one is missing or incomplete, invalid ordering provider name. This would be missing from the claim, or maybe it's invalid. Sometimes the information is transposed when it's uploaded or keyed into the system. And finally, the last one on the common rejections that I've included for today's education is an the investigational device exemption number, which is required when you're billing such, is missing from the claim, and there were 19 of those. Earlier I mentioned to you that we can look at data based on the claim or the rejection reason or the denial reason. In this case it's rejections, that's what we're talking about now, but we can also look at rejections by CPT code or HCPCS codes. We can see the number of claims denied, and remember those filters that I set when I dug up the data for this particular webinar today. These are all ASC claims, Part B claims for that time frame that we talked about earlier. Only those claims in WPS Jurisdiction 5 and Jurisdiction 8. I included all states. And the number one, the top rejected code is 66984, which is a cataract extraction with lens implant. There were 472 rejections for ASCs during that time period, and you can see the other codes there as well. Now, one thing you need to keep in mind when you're looking at rejections and denials, and we need to keep this in mind, of course, at WPS, is sometimes there's a really good reason for that rejection. Sometimes there's a secondary procedure and we bundle payment, so obviously we're going to reject the second procedure or deny the second procedure. And I'm just kind of pulling this together as an example. We know, in other words, that sometimes it is right to reject or it is right to deny. Now, you really don't need to submit denied services to Medicare if they're non-covered, never covered. If Medicare can cover them, then of course you should include that information on your claim. But for denials that are statutorily excluded from Medicare coverage, you wouldn't need to submit the claim. But these are those common rejected CPT or HCPCS codes and the numbers there. You can see colonoscopy is here. It doesn't meet the criteria for high risk, so we denied this, rejected. There, I did it. Guilty. We rejected it 238 times, and other codes there as well. So this then, remember I mentioned to you that CMS expects the MACs to use data to determine what type of education we need to offer. So these are the kind of things we look at. What CPT codes and what HCPCS codes are most commonly rejected or denied? Which are most problematic? Maybe we should consider creating education on those. And for many of these, you will find that there is education on our website. There is education out on our YouTube channel and so on and so forth. So just some things to keep in mind, that we will take corrective actions so that providers can avoid these denials or rejections on future claims. All right, let's talk about how to correct a rejected claim. This slide provides actually a link to a great resource on our website. Oh, I got ahead of myself here. Went too far. I apologize. Or I turned too many pages, and I do have to apologize for that. Remember I mentioned to you that we can look at trending, so I wanted to give you a couple of examples. So those trending reports that we can pull or export from that claims dashboard I talked about, I looked at a couple. I looked at invalid or missing modifiers. So what that trending shows is it shows the claim count for the current 3 months, for the prior 3 months, the difference in claims it tells me, and then it will tell you whether the change is plus or negative. So for invalid or missing provider, we know that that changed. It went up, increased 96%. There was 309 claims this current 3-month reporting period, but the 3 months prior to that there was 158. So this tells me, maybe I need to check something to see if there was a claims processing issue. Maybe one provider had a lot of errors because they submitted a file incorrectly, by mistake. Those things happen. So we have to make sure that we rule out reasons or reasons why a claim should indeed reject or deny. The other one that I pulled for trending is the referring physician number invalid and missing. In that case, we had a minus 48% in change for those claims. So that's good news, okay? And this is one way that we can look at to see if our education is effective. If we do a webinar on a particular denial reason, was it effective? Did it help? That's what we're looking for. And that's what CMS is looking for. So this then addresses, I had gotten ahead of myself earlier, how to identify unprocessables. You're going to have that CO16 on the claim. And what you're going to need to do is correct whatever's incomplete or missing, invalid. Here is the resource for you. When I mentioned to you the claims guideline that tells you what goes in item 1, what goes in item 2, what has to be in item 11 on a claim. So you'll find that in chapter 26 of the Internet Only Manual. That's the claims processing manual. And then, because most of you submit electronically, we have a crosswalk that says, basically it says, if you are required to put this in item 11 on a paper claim, where does it go on an electronic claim? And that's what that crosswalk document is. That is a document that is maintained and kept by our EDI department. All right, let's move on. I want to talk about a process claim. This is a graphic that shows the path for a process claim. You're going to provide the service, submit the claim. We're either going to pay the claim or deny it. And then, of course, the remittance notice is sent to the provider. So here then are the common denials for those filtered results when I looked at the claims dashboard. Medicare does not pay separately for this service. That was a denial in this case, 5,238 claims. That means payment was bundled. Okay. Payment included in another service, very, very similar to a bundled service. It's another type of bundling, edit or audit within the claims processing system. Look at the next two. Duplicate charge of a claim now being processed or duplicate charge already paid on a previously submitted claims. That's over 1,100 claims, folks, for duplicate services. This is a big time stealer. It's an expensive rejection or denial rather for both Medicare and providers. Claims are being submitted when they're already in the system being processed. So that's why it's important to check that claim status. You know, don't submit a new claim simply because you haven't gotten the remit on the previous claim. That might be within the claims processing system at the time, or maybe it was already paid. Maybe you use a billing service that the 30th of every month they submit a batch of claims to Medicare if they haven't received notice on payment. That's really abusive. Medicare reviews it as considers it as abusive. It shouldn't be resubmitted automatically. You know, obviously there's times when you need to resubmit a claim, but we want to avoid those duplicate denials. Let's take a look at the next one. 513 claims denied because the claim must be sent to the employer group health plan first. That means that that beneficiary has other insurance that's primary, Medicare is secondary. So the service is denied, you need to submit that claim to the EGHP first. The next one, I see I have a typo there, and I do that often with that word, units. It should be, not unites. So denied service or units of service are exceeded. For that one, you can avoid that by checking out your medically unlikely edits that are published. Not all codes have a published MUE though out on the CMS website. Those are National Correct Coding Initiative edits. And it just means that you billed in excess of the number that CMS says we can pay. However, you have the right to appeal, and sometimes we can pay more based on the documentation that you provide. Medicare will not pay for this service for this condition, 203 rejections. That's typically tied to either a national or local policy. Not covered in this place of service, 169 claims denied. Where there is the list of covered ASC services out available on the CMS website. I talked about that in a recent webinar that I facilitated on the 16th of this month. If you missed it, you can find it out in the encore presentations on our webpage, or you can find it out in the WPS-GHA YouTube channel. So if you missed it, check that out. I talk about that list of what Medicare can pay, make payment on when the service is rendered in an ASC. And of course, it would have to meet all of the coverage parameters or coverage guidelines for that particular item or service. A couple more there related to Medicare secondary payer issues, expenses incurred prior to coverage. Here again is a situation where you would need to ask to see that beneficiary's Medicare card to determine eligibility for your patient. Sometimes this would be for a provider that the provider billed before they were eligible to bill. So there are denials then on Medicare claims. Those would be situations where you might want to reach out to provider enrollment to make sure the information in the file is correct. Here then are denials, common denials by CPT and HCPCS codes. Over 1,000 for nerve block, paravertebral, spinal nerves and branches. I can tell you that I recognize the first few on this list, almost all of them, with the exception of the last two, are policy related. I understand that our medical review Staff has been working with provider outreach and education, and we've been providing a lot of education on those facet joint injections. Take a look at that information. It's available out on the YouTube channel, those previously recorded webinars that we've had if you need to avoid these denials in the future. And basically, from what I know, and I'm not expert because I'm not working with MR on this particular project, is that there needs to be information in the documentation you send to Medicare for these services, and if it's not there, we can't pay for it. So a couple others there: arthroscopy and an endoscopy procedure that's being denied often. Here then is the information on trending for denials. I picked out a couple again. One was up 2,343%. Duplicates took a huge jump here. Was 177 in the current 3-month period. Well, it was only one in the 3-month period prior to that. 2,343%. So this would be, of course, something where we would want to consider whether a duplicate file was submitted by a provider to determine, because that number just looks a little bit off. So in terms of when we decide we need to educate on something, those are the kind of things we would need to consider. Top one there: Medicare will not pay for this service for this condition. That's policy related. 203 in the current months, 124, so we're up 64%. Now you can find denial tips or a resource on our website that will help you correct rejections, kind of like the one we have for rejections. For denials, we have a resource that's called Common Claim Denials. I've included the link here for you, and it provides scenarios of what actions providers should take to avoid those denials in the future. It's actually sorted. When you look at that resource on our website, it's sorted by denial category. You can see them listed on the slide. We have and we actually show you the reason or remark code, so you can zoom in. Well, if you see a particular reason or remark code that appears on your remit, that's what you want to look for in this particular resource, so you can avoid that error in the future. Bundling, duplicate claims, entitlement denials, payer or contractor denials. This means you're sending your claim to the wrong contractor. And of course, provider number claim denials is 2. I mentioned to you that I was going to talk about some of the processes to correct clerical errors, and one of them is the clerical error reopening. These are those minor errors, omissions that for certain items and services. So there are only certain types of clerical error reopenings, or certain types of errors that we can use this process for. And we tell you which types of errors you can render a clerical error reopening for in this resource listed here on this particular slide, How to Request a Clerical Error Reopening. It's going to tell you what you can do as a clerical error reopening, and then of course those that you can't do as a clerical error reopening. Remember, you can use the portal to do a clerical error reopening yourself. That's the quickest, fastest way. Or you can request a clerical error reopening via telephone or fax. And remember, if you're doing it yourself, using that self-service option in the portal, we do have that portal user manual that provides instructions. There is a time frame. It is 1 year from the remittance advice receipt, or the remittance advice notice date. You have to request the clerical error reopening or do the clerical error reopening out in that transactional portal. Here then is some information about appeals. We have the clerical error reopening that you can do for some denials, we have appeals that you can do for denials, but you can't do for rejections. So remember that. For claim denials, most often, I'm going to say that, you can request an appeal, and your remittance advice notice is going to tell you whether or not you have appeal rights. So most claim denials do have those appeal rights. Physicians, suppliers, and beneficiaries can request an appeal. They have the right to an appeal claim determination made by the MAC. The beneficiary or their representative may request an appeal on any service processed for them. Providers and suppliers can appeal, though, only for those services on which they accepted assignment. And for unassigned claims, your providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign that authorization statement in order for that to happen. The first level of appeal is one that's called a redetermination, and this is the only level of an appeal that is rendered by the MAC. So WPSGHA can render an appeal. It will be a redetermination, only level 1 appeal. Time frames apply to every single level, all 5 levels of appeal. Additionally, I don't know if you're aware of this, but there is a time frame that the contractor that's rendering the decision has to follow. Also, that CMS stipulates in their rules and guidelines and such. For levels 3 and 5, there is a minimum amount in controversy that applies. That means a certain dollar amount you must meet in order to request that level 3 or level 5 level of appeal. But you can combine similar denials or like denials on more than one claim or for more than one patient in order to reach that amount in controversy. The amount in controversy can change every year. All of this great information about appeals, the 5 levels, the time frames and such, the amounts in controversy, are included in a resource we have on our website. It's there on this slide, How to Appeal a Claim Determination. CMS also publishes every year, and I really love this document. It's a flow chart, and it shows those levels of appeal, the time frames, and the amounts and controversies as well. They have not yet updated it to 2024, but it's out there for 2023. I think they'll get the 2024 one out there fairly soon. All right, last but not least, I do want to mention to you that we do have a timely topics document that we prepare and have available out on our live events webpage. And we do this because sometimes CMS comes to us and says, you need to tell providers about this every single time you host an event. So we do this by letting you know there's a timely topics document out there. There's a link on our live events webpage. I talked to you earlier about our YouTube channel. Here's where you can find the link to our YouTube channel. We have multiple playlists and videos that are available out on the YouTube channel. Remember that recordings stay out on our website, on our Encore Presentations webpage, for only 90 days. If you haven't noticed, we have redesigned our website. It is new and better, I think better. Most of the feedback we've had is very, very positive, and the reason for that is because we redesigned the website, but we based it on what our providers asked for. If you've not already done so, please subscribe to eNews so that you can stay on top of information. I'm going to pause just for a moment and ask Bailey if there are any questions that may have come in related to what we're talking about today. If you have a provider-specific or claim-specific question, that needs to go to customer service. But if there's something that I talked about today that you have a question on, I can take your question. So we'll pause just for a moment, and Bailey, I'll let you know when we're ready. All right, Bailey, I'm ready for those questions.
Okay, so we have one that came in, and it says, how do you get patients/physicians to send an ASC insurance cards before the procedure occurs?
Well, that's a great question. So what you'll need to do is you'll need to ask the patient for that information before the procedure. So those folks maybe that are working in your scheduling department need to let the beneficiary know that you need a copy of that card. But that's when I would ask them for that information. I realize they're coming in from other facilities at times, but you do need that information in order to submit the claim to Medicare. So you will need it before the procedure occurs. And remember that you'll also need to consider whether or not you need to present an ABN to your patient, that advance beneficiary notice of non-coverage. If you believe that Medicare may deny your service because or due to medical necessity reasons, you need to present that in advance and have the beneficiary sign it in order for you not to be liable for those for those costs if we deny the claim. Any other questions, Bailey?
Yes, we actually just had one come in. Why are we not able to submit redeterminations until after 7 a.m. Central Time? Why is the website limited during certain hours to use most of its functions?
That's a good question that I honestly don't know the answer to, but I believe it's because of the numerous updates that are run with the system that occurs each and every night. That could be the reason, but you know, I'm happy to ask a subject matter expert, someone who works in redeterminations, why we don't have that function available, you know, a greater bit of time. Now, keeping in mind, of course, that some of our providers are, you know, on Pacific time, some are on Mountain time. We have Part A providers that are on Pacific time, of course, Mountain time. We have those of you that are on Eastern time. I don't really know why they chose that time. If you'd like, I can do a little more digging with those that work in appeals and ask them why. And I'll be happy to follow up and send that out to everyone. Any other questions, Bailey?
Nope, no other questions.
All right, and I am 1 minute past the hour, but I don't want to leave without thanking you for being a great audience. Please remember to check our e-news, our website, our YouTube channel for more WPS education opportunities. And speaking of, your greatest compliment would be for you to recommend our education. There's a lot of ways you can get it to others within your organization or outside of your organization. We want to make certain that everyone is getting needed information. So thanks again for being a great audience. At this time, you can disconnect from this webinar. It's concluded. Thank you.